So this morning we have the pleasure of having one last talk, followed by some workshops and a closing panel about next steps. The next speaker is, some of you have been in his workshops, and maybe some of you have been working with him for years, is Mitchell Levy. And Mitchell, this is really the first time we've spent time together, aside from meeting each other in the aisle in the auditorium. But one of the things about Mitchell is that most important, is that he brings his heart to where he is. And he's a Buddhist teacher and clinician, and let's all enjoy his heart.
So I want to echo what JB and BJ said yesterday. I want to thank Koshin and Chodo and Craig and especially Mary for hosting this incredible conference. For me, this is such a luxury. We met with the keynotes yesterday, and I said it was a pleasure to be in a room with faculty that I really wanted to be in the room with. That's not always the case in my profession. And this has been just such a luxury to spend time together and listen to these wonderful keynotes and share our experiences. And as Ira said, I'm very keenly aware of the fact that any one of you could be up here giving this talk. And I think that's the power of this kind of conference, that we're all caregivers together, and we all have such important, powerful experiences to share. And being able to do this together is a luxury that I hope they keep doing again and again and again. So I want to, oh, by the way, I should say something about these photos that you're going to see interspersed. It's following along the lines of what BJ said yesterday. This is art that is from two artist photographers in New York City, Bastian Schmidt and Philippe Chang. And they've done a lot of work photographing grief and death across the world, but mainly North America and a little bit in Latin America. They work with black and white and natural lighting, and they pay a lot of attention to hands. And I first met them on Bourbon Street in New Orleans, and I went there. It was an opening, and walked in, of course, with a cup of something in my hand, and looked at their work, and I said, I have to get you into my intensive care unit. And so we got both of them. I got a grant. Actually, the grant was from Ira Bayek, who's not here, but he and Robert Wood Johnson funded a lot of our work. And the two of them came into our ICU for 2 weeks with cameras and just film. They became part of the family, actually. And it was interesting because they were in the intensive care unit. And when they first came in, the nursing staff said, well, we'll never get consent from these patients to film them and to shoot them. And of course, over the course of 2 weeks, only one patient said no. And we have an 18-bed medical intensive care unit. And we all know, and we heard this last night with those beautiful readings, our patients want to be witnessed. They already feel alienated. And the ability to be witnessed and expose themselves is a wonderful opportunity. And you'll see from these photos as we go along some of the beautiful work they've done. All I asked from them was to portray the luminosity of grief and death in the intensive care unit rather than just the technology. And you'll see, I think you'll agree that they've done an amazing job. So my title is Dignity in Death, Applying the Practice of Mindfulness to Improve End-of-Life Care. But I'm not really going to talk that much about mindfulness. This is the last keynote, and I want to talk a little bit as you leave and remind us of things that we all already know, but just some things, some concepts worthy of contemplation that empower us as caregivers who work with people who face serious illness and the end of life. And as a typical physician scientist, I'm going to show you data and state the obvious and prove that common sense is common sense. And you all know, and you're going to see this from some of the data, that we take great pride in proving the sky is blue, people are suffering when they face death, and if we're kind to them, they appreciate it. Profound. It's so good to be an academic scientist in this field. All right, so dignity. And I started this because this is what we are all, as caregivers, striving for in our work, and what we see in our patients that they forget they have in illness, in serious illness, and when they face death. And so in many ways, more than alleviating suffering and the pain we see people face when they're dying, what we're really trying to do, and I know you all know this, is restore a sense of dignity and openness to our patients as they face death. So really, just again, stating the obvious, what is dignity? And I know that if I asked everybody, we would have a slightly different description, but essentially we would be saying the same thing. And Torona said it so well, it's feeling good about who we are. Whether we're healthy, whether we're sick, whether we're getting old, whether we're feeble, whether we're dying, there's still a possibility, and I'm going to say that throughout my talk, of discovering our inherent dignity. And that, in many ways, is why we're all in this room. Because certainly, we're not in this room because we like feeling other people's pain. And the more pain they have, the better. I hope that's not why we're here. We're here because we feel that we, as healers, we have the possibility of restoring a sense of unconditional healthiness and fundamental dignity to our patients in the midst of the dying process. In many ways, and I know you all know this, it's what keeps us going. It's why we do what we do. That what feels good about what we do is that at the end of working with some of our patients, we feel not only that we've given our best, but we've brought out the best in them. That we're able to heal them, as Ira said, and we all know, during the dying process. So a sense of being worthy. We come from a culture, my teacher says that we have, all of us, have a lineage of no mistake. That it's possible to lead our lives not apologizing for something. And so much of our culture, and our Judeo-Christian culture, is that really we should start by apologizing. We've all done something wrong. Now, growing up as a Jewish boy in Brooklyn, I really know that. And if I didn't know that, my mother reminded me of it constantly. So this sense of natural worthiness and natural health and natural dignity is something that's possible to discover in ourselves and role model that for our patients as they go through the dying process and the process of illness. And as I said already, we know that it's inherent in the human condition. All we have to do is look for it. We have to uncover it. And that's what we do with our patients, is help them rediscover their inherent goodness, their inherent healthiness, and their inherent dignity. And we also know, which is why we're here, that it's undermined by illness. It's undermined by physical illness, and it's undermined by the culture in which we live that says if you're sick, if you're old, you're not worthy. People don't say it out loud, but they say it by the way we act. So this one is my favorite picture, by the way. The acts of kindness that happen in an intensive care unit that often go unnoticed by families, but are always appreciated by patients. This is the act of restoring dignity to someone who's lying in an intensive care unit bed and just having her hair combed in the midst of critical illness. So I'm going to remind us about our state of dying in our culture, which we all know, but it's worth, as we leave, to talk a little bit about how we got here and what can we do to re-empower ourselves and our patients during the dying process. So fear of death, and we've talked about this throughout 3 days, is the cultural avoidance and hiding of death permeates our culture. I've said in the workshop, and we all know that the one thing that marks our culture is we hide death. We think our children shouldn't see dying patients. Our hospitals, I work in an intensive care unit, but when you go in a hospital in developed countries, the one thing that marks that process, as opposed to when you visit hospitals in developing countries, is the smell. When we go into our hospitals, you don't smell infection. You don't smell death. You smell antiseptic. And so we live this illusion that life is clean, life is pure, life is germ-free. Death is good. Or we don't know what death is. So we hide it. And of course, as we hide it, we become embarrassed when we get sick. So there's a natural cultural reaction that we all foster about alienation and embarrassment about illness and death. And that's where we are. Even after all these years of hospice work, in my field, research on how to die well, which has been going on for 20 years, still what permeates our culture is a sense of embarrassment about getting old and dying. The healthcare environment. So how many of you work inside an acute care hospital? Right. So hospitals are no place to be sick in. They really aren't. I mean, people who say, I want to go home, that's a sign of wisdom and intelligence. I mean, I've been a patient in my own intensive care unit, and it's really a horrible place to be. Of course, if you need it, it's a good place to be, but it's speedy, chaotic, frenetic, and it absolutely does not lend itself to good, open, present communication. It's antithetical to it. So it's not surprising that patients feel more alienated when they seek help, when they seek medical help, than when they're at home feeling sorry for ourselves and being sick. We're not trained. It's remarkable how poorly trained caregivers are for dealing with death. We're not trained in how to deal with heightened emotion. We're not trained in cultural differences. When we confront the common instance of family conflicts during serious illness and death, we have no training whatsoever. And often, unfortunately, we don't ask for help as caregivers. Now, I'm not just talking about physicians. As a physician, I'm going to keep reminding us how bad physicians are at this, but I see it in nurses, I see it in social workers, I see it in hospice workers, I see it in all of us, I see it in myself. Our lack of training, our lack of learning how to be present and open ourselves up to the grief and pain around dying causes a lot of unnecessary suffering in our patients and their loved ones. The remarkable thing is, especially for physicians, we're not trained how to listen. Well, when you think about that, when I do these classes for caregivers for physicians, I ask how many physicians have had a course in communication skills and listening skills in their medical school or residency, and no one raises their hand. Every once in a while, someone will raise their hand, and it's remarkable. It's the one thing caregivers do the most. And yet, what our medical system trains caregivers to do is to make the right diagnosis. That's what identifies a good caregiver. Not listening, but making the right diagnosis. So again, it's not surprising that we don't know how to deal with death. And it's not surprising that all of this lack of training and this speed and chaos leads to an instinctive almost reaction, which is avoidance behavior. As caregivers and as patients, when we are faced with serious illness, the prospect of our life being shortened, we avoid it. We avoid it in ourselves, and we avoid it in our patients and their loved ones. So now I'm going to show you some of that obvious data. Now, I know we all know it really matters, but I just want to paint the picture of why we're all here at this kind of conference and what we can take home. So, of course, it really matters. First of all, and this is specific to critical care, but these are data that we published in 2004, 20% of Americans die in the intensive care unit. So that's amazing. 1 out of every 5 Americans breathe their last breath in an intensive care unit. No other culture in the world is like that, fortunately. It's frightening when you think of the slides I just showed you in terms of how poorly skilled we are at communication and listening, that 1 out of every 5 Americans will breathe their last breath in an ICU that often has limited, restricting visiting hours. This is a study that was done in France, and relatively old, it's from 2001, But it's a great study because it was 43 intensive care units and about 1,000 families. And basically what they found, again, not exactly rocket science, was a high prevalence and incidence of anxiety and depression amongst family members. But what was found in the study was one of the factors that was strongly correlated with the incidence of prevalence, the incidence of depression and anxiety was a lack of regular meetings with physicians and receiving contradictory information. So really good information that suggests that we need to learn as physicians, nurses, hospice workers, social workers, respiratory therapists, I'm sure I'm leaving someone out, pharmacists, how to talk to patients and how to work as a team so we're all giving the same message to people as they face serious illness and death. Not only that, but it lasts a long time. This is a great study that asked family members a year after they had these end-of-life conversations and lost their loved ones, what do they remember? And 50% of them remembered conflict with physicians. So we underestimate the impact. Now, probably we don't. And part of the problem is whenever we do conferences like this, although glorious, we're always preaching to the choir. Who I really want to be talking to are all the people who looked at that flyer and said, please, I'm not going to waste my time going there, and then go and take care of dying patients. Because we all know the luck of the draw is on any given day, a patient may come into an acute care situation and they'll either meet one of us or they'll meet one of our colleagues who's not trained, who doesn't pay attention when we're talking to patients. And it's just karma. It's just the luck of the draw. And you see the profound impact it has on families after the death of their loved one, depending on who they meet in an acute care setting, and it's just to show you that it's actually shown. So why are patients and families frustrated with our communication skills? So I want to show you a couple of studies that you actually really couldn't even invent if you tried. This is Jim Tulsky, who's a very highly regarded ethicist in Rochester, and this is a general internal medicine population. And basically, they just did audio tapes of 87 patient physicians' discussion. And the thing they found, which is wonderful, is that in these audio tapes, physicians spend 75% of the time talking. And 25% of the time did they let patients. Now think about that. If you went home after this and you said to your significant other, oh, here's the deal. I learned something at this conference. I'm going to talk 75% of the time from now on, and you get to talk 25%. It's not the foundation of a really good relationship. And yet, this is exactly what we do with our patients. And in fact, when I gave this talk, which I do a lot, about 6 months ago, one of the physicians in the question and answer period said, I don't really see a problem with this number. I'm not making this up. Patients want to hear us talk. They want to hear about diagnosis. What do they have to say anyway? They really do want to hear what we have to say. And just to show you that it's not an isolated study, this is Randy Curtis's work. Randy is probably one of the foremost researchers in end-of-life care in the world today, and he has one of the best intensive care units in terms of end-of-life care and communication skills. He did the same study with his docs in the ICU and found the exact same numbers, 70-30 split. So already you can see something that we all know, that we talk too much. And when we think about it, when you feel miserable, and when we see people or have loved ones who are dying or facing death or serious illness, they often don't want you to talk to them. And that's why sometimes they don't want to be visited. They want you to just be present, open, nurturing, kind. They don't want a lot of words. And they certainly don't want one-liners geared towards making you feel better because I'm uncomfortable and I don't know what to say. So this is just stating the obvious. This is another study from 2008 that measured the number of empathic statements in family meetings. And you can see here that the large percentage of the conferences actually had none. Again, really good reflection of the fact that the reason we come to these meetings, the reason this conference is so important, and the reason it's so important that we keep going is because we have to learn how to stop and just learn how to be empathetic, deeply empathetic with our patients. And that's sort of where I want to go next. So in the few minutes that I have, I'm going to talk about the things that I think we can do. Mindfulness is one of them. But first, I think we can appreciate compassion and impermanence, and I'm going to talk about that in a minute and in the workshop, as the ground for accompanying others at the end of life. We can begin to make a personal relationship with death. We can learn to work with the discomfort that arises out of the constant uncertainty we face as caregivers and as patients as ourselves. And finally, we can practice mindfulness and use mindfulness as a tool to be present and open in patients and their loved ones who are facing serious illness. So let's talk a little bit about impermanence and change, because I think it's the foundation and often the first step in making a genuine connection with patients and their loved ones who are facing loss in serious illness and in the dying process. I'm not saying anything you don't know, but impermanence is the willingness to face and experience things as they are. Now, for a lot of our patients and their loved ones, things as they are facing death, which gives birth to the grief and sense of loss. And I suggest that impermanence is the start of where we fear death, that sense of loss. But the truth is, no one can deny the fact that there is birth, old age, sickness, and death. This is not a Buddhist concept. As far as I know, you might be able to avoid getting old, but even then, most humans, even if they die quickly after birth, you could argue there's some aging process involved. So as soon as we appear on this earth, we are automatically aging, our bodies inevitably will break down, and eventually will face death. This is an important truth of change that we can impart to ourselves, our patients, and their loved ones in the face of loss and grief. That it's inevitable. That doesn't mean it's cheerful, but birth, old age, sickness, and death is a truth of being born that we cannot avoid. And I suggest this contemplation of impermanence, and we're going to do this in the workshop, not to make us feel good about the fact that we're dying, but to recognize the inevitability of it, so when we as caregivers face the grief, the intensity of grief that comes out of facing loss in our patients and their loved ones, we can hold ourselves. We can open ourselves up to it and not automatically develop avoidance behavior. We can embrace the inevitability of loss and change and hold and rest and be present. That's the value and power of contemplating impermanence. And the point here is that inevitably, because of impermanence, we feel helpless in the face of change, but that doesn't mean we, our patients, and their loved ones have to feel hopeless in the face of change. And I know so many of the keynotes have spoken about this over the course of these 3 days, that we can have tremendous hopefulness and tremendous luminosity of life in the face of feeling completely helpless in change and serious illness and death. Life is transient, changing, and impermanent. This is the experience of grief. And as I've said in the workshop yesterday, and I'm going to talk about again today, the contemplation of impermanence as caregivers allows us to experience true grief, even if it's over the loss of a friend because they've moved away. As a lot of caregivers, I train a lot of interns and residents, and so many of them haven't really experienced death. So I often ask them to contemplate what they've lost in their life that's not death, as a way of allowing them to begin to experience what grief is. Because I would venture to say that that grief that we experience out of the loss of a dear friend moving away is the same grief. It has the same texture that someone who's been married for 50 years and is facing losing their partner of 50 years in the intensive care unit. Grief is grief. Loss is loss. And the beginning of empathy is finding a way through contemplation to evoke your own sense of loss and grief when you're working with patients. So impermanence can be the beginning of a meaningful relationship with patients who are facing loss. And through that inevitability of change, we can maintain hopefulness and joy, and you've heard that from everybody. That's what keeps us going. We've talked about this for 3 days. I just said it again. The reason what we have to offer patients who are facing serious illness and death is helping them rediscover the joy and dignity of being alive. Now, fortunately, or unfortunately, a death sentence is often in our culture what it takes for people to live. And it's ironic that we hear people say, I never really saw the beauty of the sky and the beauty of flowers. I never appreciated how luminous and wonderful it is to be alive until I realized that I was going to die soon. And it's a sad commentary on our culture that we go through life numb until we get a death sentence, and then we look around and go, holy shit. Wow, life, this is really beautiful. I live in this really beautiful world. So what we can do as caregivers is restore that to people who are still so much in the throes of grieving and loss that they can't see it. And we have the possibility by being present and open and mindful and listening to restore that sense of wonder to patients when they face serious illness and the dying process. Making a personal relationship with death. So, I was asked to edit a book, to write a chapter for a book called Managing Death in the ICU, and they asked me to choose a chapter. And I looked, and it had every chapter you can imagine, managing sedation, counseling, but there was no chapter on making a personal relationship with death, which is remarkable. How can we be a caregiver dealing with serious illness and death if we don't have any contemplative practice about our own dying process? So in the interest of time, I'm going to stop, and I'm not going to say anything more about making a personal relationship with death, except that we have to do it. Now, for some of us who faced serious illness, it's easier. But many of us have the sort of good fortune of not facing serious illness or death, and we must have our own contemplation of death, or we cannot face a patient who is facing death and have any insight into what they're experiencing. Now, that's an extreme statement, but I think most of you know that's true. And you see it in caregivers who are talking to patients who are dying, and they are clueless about the things that they're experiencing. And they say, I know what you're feeling. Bullshit. They don't know what they're feeling. All right. I'm going to skip over this because I'm running out of time. I want to touch on this because I think this is what is a constant challenge for all of us who deal with patients who are and families. We all get asked, especially for me, because I'm the person who comes in, the Grim Reaper, and withdraws life-sustaining therapy, and the families say, how long do you think it's going to be? Or as hospice workers, the family, after they have been talked to by the physicians, and of course don't listen, because they're in so much grief, they say, what did he say? What did she say? How long do I have? We have no idea. Is there anything as humans or as caregivers that we're certain about? Absolutely not. And you heard from BJ it was BJ yesterday who said, I'm not even sure I agree with the definition of death. So for many cultural differences, our definition of death is even different. So we're not even certain about death. And yet we constantly are asked about prognosis, diagnosis, timing, cause, and the only thing we could say is, I don't know. So it's, again, an important contemplation to recognize that we have to learn how to be uncomfortable with constant uncertainty, and how we communicate in the midst of that uncertainty, comfort. How we communicate comfort in the midst of our uncertainty. And we see all the time in fellow caregivers that discomfort, and the body starts to move around and they start to get jittery and their leg might start to go because they don't know. We don't know. And instead of being open and present and staying with the patient's grief and longing for certainty, we make something up. We do a humorous one-liner as a way to deflect our discomfort with uncertainty. So I'm running out of time. So I'm just going to leave you with a few things. To me, the challenge we have is, can we learn to be comfortable, to rest, to dwell in uncertainty, in the discomfort of the dying process? And that's where I think the power of mindfulness comes in. That we can, through the practice of mindfulness, through relating to our posture, learn how to hold ourselves upright, open, and present with our patients and their loved ones in the midst of grief and loss and uncertainty. And what we can learn to communicate in that process of holding a good posture and being fully present is the upliftedness of the natural dignity that's inherent in the human condition, that's not diminished by dying. In fact, it's heightened by it. So let's just do this for a second. Let's just sit up. Because what I suggest, and I'm going to do this in the workshop, and I work with my interns and residents, is, and I would strongly suggest that we do this for those of us who are sitting in a chair, because I use this in family meetings where you feel your feet on the ground, straight back, good head and shoulders, soft front, strong back. And from this space, we can be open, present, and contain the uncertainty, the grief, and the fear of our patients and their loved ones. We can make a difference. We do make a difference. And that difference is right here. Thank you.